Hi, my name is Ian Davis. I'm a medical oncologist from Monash University and Eastern Health in Australia. I'm also chair of ANZAMET Cancer Trials Group. And I'm here at the ASCO 2019 meeting where we've heard a lot of interesting information about developments in treatment of prostate cancer. Pleased to be talking with you, Axel Merseburger, a urologist from Germany. Axel, you've been involved in the Titan clinical trial, which generated a lot of interest a few days ago. Can you give us some information about that?
Ian, thanks a lot. Thanks for introduction. It's an honor to be here, and I'm flattered to be involved in this trial. It was presented a couple of days ago by Kim Chi from Vancouver. We all know him. He's publishing a lot of game changers, and I think a couple of days ago this was another game changer. It was apalutamide in a randomized phase 3 trial, recruiting more than 1,000 patients one-to-one. ADT plus apalutamide versus ADT and placebo in primary metastatic, de novo metastatic, as we could say, prostate cancer. In this situation, this resulted in a 33% reduction of death and also a 66% reduction of progression. So hazard ratio 0.67 for death, for overall survival, and 0.48. So this, I think, is really clinical relevant for the combination apalutamide and ADT versus standard ADT treatment in this situation.
And how is the treatment tolerated?
So when looking at the adverse events, and especially the adverse events of interest, it was in the ones we want to know as clinicians, grade 3 and 4, it was equally balanced, 42% versus 43% in both arms, so no real relevant differences. In apalutamide, we had a little bit more rash, which has to be known, but it can be managed by topical corticosteroids, or I had some patients where we just stopped the treatment for a week and then restarted and the rash disappeared. Don't ask me about the mechanism, but I will consult my dermatologist. Yeah. So safety profile was there, and I think this is something what was new. But on the other hand, I've learned a lot from ENZAMET yesterday, a presentation by Chris Sweeney, where you were the first author in ENZAMET, now published also in New England Journal of Medicine. Congratulations. So,
and on yours, yeah.
Yeah. So what is your perspective, or how do you see the differences among those two trials?
So ENZAMET was a very similar concept. So men starting androgen deprivation therapy for metastatic hormone-sensitive prostate cancer were randomized to receive enzalutamide, or a standard anti-androgen, bicalutamide, flutamide, or nilutamide, which is one of the distinguishing factors of ENZAMET from Titan and Archers. And we found a very similar outcome. So the hazard ratio for overall survival for the whole population, again, was 0.67 in favour of enzalutamide, and about a 60% reduction in the risk of PSA or clinical progression. We saw pretty much the expected enzalutamide side effects. One other distinguishing factor of the study was about 45% of patients also received concurrent docetaxel. So there's been a lot of interest. 45 to 50%, depending on the arm, received concurrent docetaxel. There's been a lot of interest about that triplet therapy. What we found with that was that there was no additional benefit for a man who was on testosterone suppression and docetaxel at physician choice. To add enzalutamide on top of that appeared to give no additional overall survival benefit at this first interim analysis. We did see a signal in favour of progression-free survival, but so far no survival benefit. So, and in addition to that, we did see more toxicity with the combination. So it's yet to be determined whether there might be a long-term advantage. A survival benefit may yet declare itself. This is just our first interim analysis after 50% of the expected deaths. But right now, we cannot recommend that men should have the triplet combination of androgen deprivation therapy, docetaxel, and enzalutamide.
So you would agree that, like starting with apalutamide, once it's approved, since we have the Titan data now, makes sense, and you rather use the sequence, like in Titan, 11% of the patient had upfront docetaxel, and then later on had treatment with apalutamide and ADT. Learned from ENZAMET data that the combination, the triple therapy, probably doesn't make sense as of yet, as you just alluded to in the first interim analysis. Would you agree, or what would be your sequence 2019?
So I should say that ENZAMET was not designed to answer the docetaxel question. That came in after the charted data were published in 2014. And uptake was quite good, but not everybody on the study received it, and it was not a randomised treatment. We did stratify for it. But I think what we have now is very clear evidence that there is value in adding additional treatment to androgen deprivation therapy. Docetaxel still works and is a very good option for patients where other treatments are not available. Abiraterone also works if that's available. Apalutamide works, enzalutamide works. But combinations of treatments beyond that, so far we've got no evidence that that's helpful, and some evidence that might actually cause additional harm. So I think that men going to talk to their doctors now should feel confident that they have several options potentially to choose from if these agents are available in their jurisdiction, and also that they should not feel that they're missing out on any treatment if they're offered one and not the other. There will be reasons why one treatment might be suitable for one man and not for the other.
Totally agree. Maybe we have to consider also the approval status for apalutamide. We have it right now in some countries in M0 CRPC. We might have it in de novo metastatic prostate cancer when we wait the Titan data. We use the Titan data now, but we will not have it as last line where we can still use docetaxel or abiraterone. So I think it's a wise decision which one to start with first, and here not to have all options available for our patients.
Yes, I think if we did have all options available, and certainly in Australia we don't, and may not for some time, then it'll be a matter of sitting down with the patient and ascertaining their own personal preferences. If there's the toxicity profile, there may be financial issues to be dealt with as well. Patient may have comorbidities that might mean one treatment is more suitable than another. So for example, if a patient has cardiac failure or diabetes, abiraterone and prednisone might not be the best option. You might want to go for one of the lutamides. If a patient has cognitive impairments or a seizure disorder, enzalutamide is probably not the best option. If a patient has financial issues or a preference to have all of their treatment out of the way very quickly, 6 cycles of docetaxel, which is very cheap, is a perfectly reasonable alternative.
Beginning of this year in San Francisco, we saw the ARCHES data. To my knowledge, it's not fully published yet, but we saw the abstract showing a benefit in PFS in enzalutamide use in primary metastatic prostate cancer. Could you allude on the ARCHES trial and what's the difference to your trial presented yesterday, the ENZAMET trial?
So there are a lot of similarities between ARCHES and ENZAMET. So the overall idea was similar, use of enzalutamide. Some differences though. So the primary endpoint for ARCHES was a co-primary endpoint of overall survival and radiographic progression-free survival. And the control arm was placebo, not standard anti-androgen. ARCHES started about 2 years after ENZAMET began to recruit, so its follow-up was shorter, median of about 14 months compared to 34 months for ENZAMET. And of course, ENZAMET was an academic study led by ANZUP Cancer Trials Group. ARCHES was industry-sponsored. But the outcomes for progression-free survival are remarkably consistent with what we've seen for ENZAMET and also for Titan. So I think we're seeing confirmatory information there. When the data were presented in February at ASCO GU, we're not yet seeing a survival benefit, but I think that's really just a function of the shorter follow-up and the low number of events that have occurred.
Okay, perfect. Thank you.
So that's all we have from ASCO 2019. It looks like we have several new options potentially available for men with prostate cancer. Thank you very much for your attention.